Let's see as soon as it goes. Sometimes it takes my computer a second.
I have a notice that we're live.
You do? Okay.
On mine, it says meeting is.
Oh, okay.
Okay, then we
Perfect.
are live. So good morning, almost afternoon, everyone. Welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We use these sessions as a work session. We have heard the bills that we're going to be discussing today. And so the purpose of this meeting is to work through any things that we have concerns or issues with, see if we can find language that meets multiple needs and perspectives, and see if we can't move bills forward. We do not always vote on the bills in these subcommittee meetings. Sometimes we need to gather some more information before our next meeting. So with that, and I will offer people who have presented an interest or testimony on any of these bills have been invited to actively participate. I would ask that if you want to participate in the discussion, provide information, that you do so by raising your hand in whatever function you have for doing that. I will call on people in the order that I see hands. I'd ask that you keep your comments concise and to the point. Many of these bills are all, three of the bills that we've talked about, or we're talking about today, we've already talked about at least once, and we know that we're trying to fix things, not engage in more discussion about what's wrong. So just, be clear that we want to move forward productively. We are going to start with HB 429, pharmacists, required notification and authorized substitution, lower cost drug or device product. Lisa Simpson, would you tell us what the bill does?
Sure. House Bill 429 permits a pharmacist to substitute a therapeutically equivalent brand name drug or device product for any originally prescribed generically equivalent drug or device product if the prescriber does not expressly state that the prescription must be dispensed only as directed. The substitution is recognized as specified, and the consumer is charged less for the substitution than the originally prescribed drug or device. There was an amendment that was emailed around from Delegate Shetty. The amendment clarifies that the determination of whether the consumer would be charged less is based on the consumer's drug benefit and formulary if it is readily available. And the amendment also clarifies that the notice requirement may be fulfilled by maintaining a record that indicates the patient has been notified in writing or orally.
Okay. Is Delegate Shetty here?
I am here, yes.
Wonderful. Delegate Shetty, would you like to speak for a moment on the bill?
Thank you,
And
Chair
the amendment?
Yes, sure. Thank you so much. I really appreciate being before you all today and having the opportunity to address this. So as you might recall, last year, this subcommittee and the entire chamber passed an amended version of HB 1119 through the chamber unanimously with the adoption of consensus amendments from a variety of stakeholders, payers, providers. We engaged with pharmaceutical companies. We engaged with basic and retailers and pharmacists. There were a couple of issues flagged in the hearing of HB 429, one by Kaiser Permanente regarding their system having difficulty in putting in writing that a therapeutic equivalent is the substitution versus what they currently have, which is that there is a generic substitution. So they requested the language about maintaining a record or having it be in writing. So that language satisfied all stakeholders of the group that we worked with. And then the second issue that was flagged flagged to us was by the Board of Pharmacy, and that was regarding the language on page 3, line 21 of the original bill. And that was related to if a consumer is using their drug coverage, their plan benefit to fill the prescription, that the determination of whether a product that's being substituted is lower cost would be made based on those drug benefits. So the Board of Pharmacy noted in their testimony that that's information is not always readily available at the point of. And so the consensus language by all stakeholders that everyone agreed to was including if that information is readily available. All stakeholders consented. There is peace in the valley yet again. So I asked the subcommittee to please consider these amendments favorably, and I'm happy to answer any questions as needed.
And we do love our peace in the valley in HGL. So let me ask, is there a motion on the amendment from the subcommittee?
Move the amendment.
It's been moved. Do I have a second?
Second.
I have a second. Discussion on the amendment or questions of the sponsor on the amendment? Delegate Saab. Delegate Saab, did you have a
Thank you,
question?
Madam Chairman. It's
Okay.
actually not on the amendment, it's on the bill, so. do you
Okay,
want
so you want to wait until we?
Yeah.
Okay.
Thank you.
Any questions on the amendment? I see no questions on the amendment. Those in favor of the amendment, please say aye.
Aye.
Anyone opposed to the amendment, please raise your hand. I see no hands. Therefore, the amendment passes unanimously. Do you have a question, Delegate Saab? Or do you want to discuss the bill?
It's both, it's a combination.
Okay, then I'm going to ask if there is a motion on the bill before we proceed with discussion. Is there?
Move the bill.
Well,
Okay, the bill has been moved. Do I have a second?
Second.
The bill has been moved and seconded. Delegate Saab and then Delegate Krebs.
thank you, Madam Chairman. Just to clarify, I think my only struggle is still with like lower versus lowest. I think this is a bill, and I think it's really beneficial. My only concern is some drugs are less expensive with coupons, versus not coupons. And so does that play into that as to say, look, I have this medicine, if you get it, we have that, and it's going to be lower out of pocket. And then the other concern that I have with this, which we do have another bill that's not a sister bill, but it's more of the some of the deductibles or the out-of-pocket cost that goes into the deductible. How does that play into that? Because maybe some of the patients would be under the impression that their out-of-pocket cost because of the coupon is going towards the deductible.
Yeah, I think you're right. Okay.
So I'm going to take a stab at that response, Delegate Shetty, and then because it is about another bill that you might not have been familiar with. You're speaking to the accumulator bill, Delegate Saab.
Yes.
It's not related to it at all. So this bill, so the person who wants to use a coupon is perfectly capable of using the coupon and, saving themselves some money. If they want to know whether or not it applies towards their deductible, they've got to call their insurance carrier. That's where they would learn that information. The pharmacist is not likely to have that information. What the pharmacist is looking for is the lower price drug so that that site at the point of purchase, the person is paying the lowest cost. Is that right, Delegate Shetty?
Yes, Madam Chair.
Okay.
So some drugs will be less expensive with the coupon versus without the coupon, generic versus that. So
Right.
I'm just thinking of unintended consequences where someone would have an issue in the future, especially since the other bill that we're debating is still in question. And I just want to make sure that this is addressed before we to make sure we have a good problem. It's a great bill. I love the bill. I'm supporting the bill. I'm just trying to figure out that we're addressing all these issues, so we don't have to come back later and fix them.
Right. I appreciate that, Delegate Saab. Delegate Krebs.
Thank you, Madam Chair. I think it's a good bill too, but I have a question about the Attorney General's letter. And they basically state that the FDA has not determined the therapeutic equivalence of brand drugs that would be substituted for one another without prescriber authorization as proposed in the bill. Any other reliable authority that could serve as an acceptable substitute. So the question is, where does the pharmacist get his information from that there is a reliable substitute, and is this accurate?
So in response to the Attorney General's feedback, I reached out to the FDA directly to ask them about this question that was raised, and they provided an official response that stated that the FDA Orange Book, which is already used by pharmacists at the pharmacy counter to determine therapeutic substitutions going from brand to generic, can be still used under this bill for generic to brand or generic to generic. The therapeutic equivalent codes note all of those. And so the pharmacists are already using this guide. The retailers provided this answer during the committee hearing as well when the question was raised, because we wanted to make sure that we had the correct answer. We had reached out to the FDA, and I'm more than happy to circulate to the full committee the FDA's official response.
No, thank you. Maybe you should circulate it to the Attorney General's office, but
I did.
Okay. All right.
Yes.
Thank you. Just wanted to address that. Thank you.
Thank you, Delegate.
Okay. Delegate Bhandari.
Move the bill.
It's been moved and seconded.
Oh, okay.
Seeing no further discussion, I'll ask for a vote. Those in favor of HB 429 as amended, please say aye.
Aye.
Anyone opposed, please raise your hand. Delegate Krebs, your hand is up. Is it still up, or are you? Okay. All right, there we go.
I was trying to vote yes. I thought we were raising our hands for yes. Sorry about that.
No, we're not raising.
I got it. I'm sorry.
That's okay. The bill passes unanimously. Thank you very much. Thank you, Delegate Shelley, for bringing us the bill and for working with the advocates to make sure it worked. And
Thank you, committee.
Okay, we are going to move. That completes the work on HB 429. We're going to move to HB 303. This is long-term care insurance prohibition on premium increases. Lisa, want to tell us what it does? Remind us.
It prohibits the carrier from increasing a premium for long-term care insurance issued to an insured or entered into by a contract holder who is 85 or older.
Okay, and is Delegate Stewart here? Delegate Stewart may be in another hearing. Delegate Stewart? Okay, he may come in a little bit later, but before I'd like to proceed here, I think that we have some folks who are going to offer us some information on this bill. I would say that Delegate Stewart has offered an amendment that we discussed last week, but I don't know that it was ever written up officially, which is that the bill would be limited to those who were 85 and older and who had purchased the product before 2005. And just to remind folks, that's about the point at which the industry began to realize they had made some gross errors in actuarially predicting the cost of long-term care. And so they redesigned the products, and the product pricing is much more realistic, and the benefit is much more realistic than those what we call legacy products before 2005. So that amendment is out there, and I asked the carriers, the long-term care carriers, to provide us with some information on impact. If we were to do it that way, what would the impact on their business be? So I believe Mr. Matt Celentano is in the room, and he has an additional he would like to include. So
thank you, Madam Chair. members of the subcommittee. I think everything that Delegate Collison just recapped is true, and I won't go through sort of the discussion we had last week. I brought a couple of people I think that might be beneficial to your discussions on this bill. With me today is Senior Actuary Jan Graber from ACLI. Jan formed before working at ACLI, which is the American Council of Life Insurers, the nation's largest state or trade association of life insurance companies. Jan was the chief actuary at the Texas Department of Insurance for 20 years and oversaw the Penn Treaty insolvency, which we talked about a little bit last week. Jan also chaired the Long-Term Care Pricing Subcommittee at NAIC, which is the National Association of Insurance Commissioners, which I think all of you are very well aware of. But Jan has way more expertise than me on this matter, and I wanted to make sure that you got it straight from the top. So with that, I'll let Jan take over for now.
Okay. Jan Graber, are you in?
Yes, I'm here. Can you hear me okay?
Yes,
Thanks,
we can.
Matthew.
Thank you.
Well, so I thought I'll just take less than 5 minutes just to kind of lay a foundation so that we have that foundation, and I think that will help with any questions that may come up. But, as you know, long-term care pays for services that provide assistance to people that have cognitive difficulties and to those that are unable to perform activities of daily living, such as eating and bathing and getting dressed. There is a misconception among Americans that Medicare will cover their long-term care expenses. Medicaid can help pay for long-term care. However, to qualify for Medicaid, a consumer needs to spend down almost all of their assets. In the United States, 10,000 people turn 65 every day. Increasingly, people are living into their 80s and their 90s, and studies report that currently 13 million Americans need long-term care, and that number is expected to rise to 27 million by 2050. HHS reports that 70% of adults who survive to age 65 will develop severe long-term care needs before they die, and 48% receive some paid care over their lifetime, with the difference then being made by informal care unpaid by family members and friends. Long-term care insurance provides significant help with these expenses. In 2018, insurance paid over $10.3 billion in claims. So this aging population needs increasing amounts of long-term care services, and these are expensive. In Maryland, the annual cost for home health care is over $57,000 a year. Assisted living will run you over $60,000 a year, and a room, a semi-private room in a nursing home will be over $120,000 a year. I know that you're aware of the challenges that we've seen. We acknowledge that there's challenges associated with the long-term care market, specifically relating to substantial increases that many policyholders have experienced. Long-term care policies were designed for premiums that were intended to be maintained at the same level over the life of the policy, based on the policyholder's age when they purchased the policy. However, designing a level premium product turned out to be very difficult due to the duration of the product. So, these products are in force 40 to 50 years, sometimes before a claim is ever paid. We've also seen challenges associated with containing cost on products with inflation protection and lifetime benefits. There's a moral hazard associated with long-term care as it currently exists. You either use it or you lose it. And so this whole difficulty associated with designing a stable product has led to a decline in the number of insurers that are actively marketing long-term care. There were over 100 carriers offering long-term care products first introduced in the early 70s, and there's less than a dozen carriers today. So, we've seen pricing challenges. These are, like you said, associated with these older legacy blocks of business. and many of these have high inflation protection and lifetime benefits. So any kind of limitation on an actuarially justified rate increase is damaging to the industry and to consumers because you're basically shifting that burden to other policyholders and the younger policyholders. And as that 85 and over cohort starts to age, more and more burden will be shifted to younger policyholders. So continual caps will drive the industry out of existence and lead to more company insolvencies. So as a real life example from the recent Penn Treaty insolvency, I remember showing this to our commissioner when I was at the Texas Department of Insurance. You have a policyholder who was currently age 84 when Penn Treaty became insolvent. They bought the policy when they were 66. They had unlimited benefits. They had a daily benefit of $260 per day. So if you do the math on that, you think about how long someone might be in an assisted living facility and then transferred to a nursing home facility. The value of that policy is well over $1 million. Well, once the treaty became insolvent, all of a sudden,
in the file I brought back,
all of a sudden that was cut to $300,000. So they lost about $700,000 in coverage because of the insolvency. So, you know, consumers are at the core of our industry, and like you, we want to protect them by ensuring that the coverage they purchased is available when they need it. And when insolvency occurs, all the choices are taken away from policyholders. I do want to let you know that consumers do have options when they're faced with a rate increase that can mitigate the entire increase. And these are increases that are sometimes close to 100%. So they can make modifications in their coverage, such as reducing inflation protection. Many might have a 5% inflation protection on their policy. They don't need that anymore. They can extend their elimination period. They can reduce their benefit. So all of these things will allow the consumer to make the choice, which is really in their best interest. And so company data has showed us that even when faced with these large rate increases, over 90% of policyholders elect to keep their coverage in place and pay the entire increased premium. Only 2 to 3% will actually terminate their coverage, and that's either voluntarily lapsing their policy or through death. And only less than 8% will actually choose to reduce their coverage. So they see the value in these policies that they've had for 20, 30, 40 years. There's also a lot of work that's being done at the state level through the NAIC and at the federal level through the recommendations that have been made through the Long-Term Care Interagency Task Force. So for these reasons, we really oppose any kind of additional cap on what would be an actuarially justified rate increase. I'm happy to answer any questions you have. So I'll pause now.
Thank you very much, Jen. That's really helpful information. I'm going to, Delegate Kelly, I see your question, but I'm going to ask someone from the MIA to speak to this issue. I think, Todd, are you going to give us some information?
I can do that. And what we had gathered is looking at the Maryland small group market, we started with the fact that we.
Oops, you're frozen. Okay, Todd is frozen. Is there someone else from the MIA who has Todd's information?
Sure.
Michael?
Hey, Adam. Yeah, thanks, Delegate.
Adam.
Adam, are you available to jump in here with some of these numbers? Adam Zimmerman.
Hello, I'm here. Everybody hear me?
Hi, Adam. Yeah.
Hello. So I'm not entirely sure what numbers Todd were going to point out, but what we estimate is that the whole 2005 date, we estimate there's approximately 17,000 policyholders in Maryland who are aged 85 and older. And of those on claim, we estimate there's about 7,000. So that takes us down to approximately 10,000 policyholders that this bill may impact.
And it's true, Adam, that when they are on claim, they are not paying the premiums, right? Once they have begun to collect the benefits, they're not paying the premiums, correct?
Yes, that's correct.
And I did have a chance to talk with Todd yesterday, and essentially when you walk through the numbers and make some, back of the envelope kinds of calculations, although Todd is much better than back of the envelope, it's about a 6% increase for the rest of the membership of a particular product. So we would see about 6% cost shift in the cost if we were to exempt this this group of folks. So is there anyone else who has information that they'd like to add? Then I will go to Delegate Kelly.
Thank you, Madam Chairman. And thanks for bringing this great information. I feel like we're so well prepared now with this. So that's really helpful to me. I guess my question was to Jan, and thank you for sharing all of that information. I have a little bit of queasiness about this approach, and I didn't hear you clearly when you listed the other remedies that were available for folks to modify their premium if they couldn't tolerate the premium increase. So my broad question, I think you attempted to answer, which is really, and I'm sorry, I'm not meaning to give a speech. I'm just trying to contextualize the question. My parents are very lucky to have long-term care insurance, but it's not a legacy product, but I'm so thankful that they have it. My former in-laws do have the legacy product, and it has saved their lives and saved the economic lives of our family. I'm very familiar with this issue, but I do think we have to have some recognition that the folks who got the legacy product have a really good deal that in general, they're not going to want to get rid of. And I think that this conversation needs to take place with that realization in mind. And I think the data that Jan broke out when she said that they could either choose to reduce their benefit period, choose to modify the inflation protection, and then there was a third thing I think that you mentioned that they could also choose to do if the premium increase is too high for their extraordinary product that I would give my right arm to be able to buy today, but cannot for myself or my parents, is not, if the inflation increase is too high for them. So could you just clarify for me what the other option available to them that also this group of people are largely not choosing to take?
Right. There are all kinds of options, and what our carriers encourage policyholders to do if they, get the premium increase notice and they can't afford it, to call them and talk to them about, long-term care policies are not standardized like you see with Medicare supplement or other, types of health insurance. So the other modification a person could make is to their elimination period. And that elimination period is usually 60 to 180 days. And it's kind of works like a deductible. And so during that period, the policyholder is responsible for paying for their long-term care needs once a claim is triggered. So, as they've aged, they may have, other resources to help pay for more of that coverage up front. And this would allow there to be a longer period before the insurance kicks in. So it works just like a deductible on your car. If you have a $500 deductible, you're going to pay more in premium than somebody that has a $1,000 deductible.
And so just to follow up, just to make sure I understand you really clearly, the folks who bought into these legacy products, by and large, are holding on to them for their dear lives because they know what a tremendous value they are. And they're not choosing to make modifications to any of those things because even at the increased premiums, as a general rule, the vast majority of people are deciding that it's worth the money because it is not something you could buy today. Even if they were 65 years old, again, it is not something that they could buy on the market today. Something even half as good is not something that they could buy on the market today.
Right. Companies, for all intents and purposes, they no longer sell that unlimited benefit period. And that is worth, a whole lot because, as we've seen, with Alzheimer's treatment, back when these products were priced back in the 70s and 80s, there weren't the assisted living facilities. And so a lot of times you went straight to a nursing home and, survival rate in a nursing home was typically less than 2 years. Well, now with all these advances in medicine, somebody could go into a nursing home with Alzheimer's and live 10 years. And so they have an unlimited benefit period. Once they trigger benefits and they hit that elimination period, they get their daily benefit for the rest of their lives. And so those products are not around anymore.
Right.
Thank you very much.
Thank you. Delegate Krebs, is it a quick question? Because we're not going to vote on this bill. And so do you have a quick question?
It just sort of is along the line of what the previous question was. So if you're a person that's an older person and you really can't afford the increase, is there something else that can be done for the person, not just that doesn't like to pay the more premium, but you haven't started collecting the benefit yet, but you really have run out of spend? There's something that person can do. I thank you for these remedies, but I'm looking at that person. What could they do?
Right, and so if they can't, a lot of times I would say that, most states do not have a cap on an actuarially justified rate increase. So you already have that 15% cap. So looking at states that, saw 100% rate increase, the drivers of those increases are the unlimited benefit period and the high inflation protection. So you may be able to, change those things, but if not, if and that would mitigate the entire increase. But let's say that you're at the most basic policy. Number one, you're probably not getting an increase anyway, because the increases are really associated with those policies that have inflation protection and lifetime benefits. But let's say that you are. All companies have to offer you the ability to stop paying premiums, and you get a paid up policy. And that paid up policy allows you to use all the premiums that you've paid in the past towards long-term care services. So there is still an option for those policyholders if they wish to completely stop paying premiums.
Okay, Delegate.
Thank you for that.
Okay. I will tell you that Delegate Stewart has agreed to work with the MIA to look at, and the carriers to look at some other potential remedies that this is, we understand the impact on this. So, we'll be in further discussion about, whether or not this might be something we want to study over the summer. So thank you all very much for the information.
Thank you.
This subcommittee is well versed now in long-term care. I really appreciate it, and the cost of long-term care. So with that concludes the work on HB 303. I would like to proceed to bills HB 123 and HB 551. And what we are doing, and before I say what the bills are, and I'd ask that folks put themselves on mute if you're not actively participating. HB 551.
Two bills,
Related to telehealth, specifically in reference, primarily, not specifically only, but primarily with respect to mental health and substance abuse disorders. But the bill was about designing how telehealth would be delivered and defining how that happens. HB 123 is the omnibus bill that really defines what telehealth is, how it looks, how it's implemented, and and how it's reimbursed. So we have inserted the appropriate pieces of 551 into the reprint that you have of 123. We tried to make sure that we've maintained the integrity of the pieces of HB 551 that were specifically asked for. So with that, let me tell you how I'd like to proceed with this bill. You have you should have received a reprint that has handwritten numbers at the bottom. If you didn't get that one, then you got the one that you came early last evening that doesn't have the handwritten changes on the bottom. I would like to spend 20 minutes on this bill today. We are not going to finish it, and I understand that, and I hope that you do. And literally go through the bill page by page and the changes of the bill page by page. So if you, as we go through the pages, if you have a concern about what's in the page, you need to tell us exactly what the concern is, why it's an issue, and if you have a suggestion of how it might be. We will go as far as we can in 20 minutes. And if we need to come back and spend a session just on the bill later this week, then we will do that. But I'd like to see how far we can get today. Everybody get the process I'd like to follow? Then I don't think there are any questions about page 1 or page 2. And if you have questions on a page, please use the raise hand function. And I'm gonna make sure that I have it. And if I, for some reason, don't see your hand, yell. So let's look at page 3. I do not believe that there are any changes on page 3 from the bill that we spoke about last week. Am I right?
Well, so on page 3, we are inserting section 15-3 of the Health General article. We're actually inserting it to repeal it, or repeal the language there. It is then going to be reinserted into 15-141.2 in a few pages. This is the way it was done in House Bill 551. So.
Okay. Any problems with that? Okay. Then we're going to move to page 4.
Delegate Cullison.
Yes.
This is Ellen Weber.
Oh, okay. I see it now. Okay.
No worries. Just wanted to identify one point, and I don't know what the implications are, but in 551, the language on page 3, I believe line 14, the program shall provide subject to the limitations of the state budget. In 551, that language was deleted, subject to the limitations of the state budget. So I wanted to put a pin on that one, so that in the event we need to come back to that, we can do that.
Okay. Thank you, Ellen, for bringing that.
Thank you.
Okay. Moving to page 4. Lisa, are there any, what are the changes on page 4 from the original, from what we saw last Thursday?
Okay, so at the bottom of page 4 and the top of page 5 of the reprint, we're replacing the definition of healthcare practitioner with the definition of healthcare provider. This is similar to the definition used in House Bill 551. It includes individuals licensed, certified, or otherwise authorized to practice under the health occupations article. and mental health and substance use disorder programs, which are included in the definition in 551. But this definition is also including DDA providers, which was not part of 551.
Lori Doyle, I see your hand.
Just a clarification. So that section, the 7.5401, is inclusive of any behavioral health program that's licensed in the state. So it could be psych rehab programs, it could be residential rehab programs, it could be crisis beds, for instance. I just wanted to make
That's
sure.
our intent. Lisa, is that's our intent?
More time for me, Lori.
Sorry.
Could you repeat what you asked? So it's everyone on this licensed under the health occupations article, everyone that is licensed, a licensed mental health or substance use disorder program under 7.5-401 of the health general article. And then every person that is licensed under Title 7, Subtitle 9.
Right. Yeah, my question was really
provide
about the
services to individuals with developmental disabilities or recipients of individual support services. If we didn't capture everyone, we can tweak the language, but that was the.
Oh, thank you. Just wanted to clarify. Thank you.
Is there any, Lori, is there anyone right off the top of your head that you think is not included here?
I'm not sure. It's just that 7.5-401 does refer to behavioral health programs licensed by the secretary. But the rest of the section goes on about basically programs that would not have to be licensed. So I just wanted to make sure that those programs that are licensed and that do use peers, because I'm assuming this refers back to page 9, that uses peers and paraprofessionals would be included under this section.
As I said, that was our intent. So if we're not meeting that intent, then we've got to, as Lisa said, we can work on that.
Thank you. Thank you.
Okay. Any other questions about page 4 or the top of page 5? All right. Then we're going to page 6. And there's, Lisa, you want to speak to the changes on page 6?
So this is page 4 of 8 of the bill and page 6 of the reprint. It adds patient reported to the definition of remote patient monitoring services, changes the definition of telehealth as it applies to Medicaid by specifying that for fiscal years 2022 and 2023, it includes video only and audio visual services, by adding store and forward communications to what is included in telehealth as was done in House Bill 551. And by inserting, and this was some Medicare guidance into Roman numeral 3.2 that specifies that telehealth does not include short telephone conversations that originated from a service provided within 7 days before the conversation, or that lead to an office visit within 24 hours or the next available appointment.
Okay. Questions and thoughts? Okay, got a few hands. Lori, is your hand still up or was that from the last one?
Sorry, I forgot to lower it. My apologies.
Okay. All right, so Ellen Weber.
Thanks very much, Delegate Collison. There were a few issues that I wanted to raise about this. Part of it is the connection that this provision then has with the reimbursement provision with regard to payment parity. And we will talk about that later on in the bill. But because the provision here combines both audio only and audio visual on lines 18 and 19 and limits those only for a 2-year period, certainly for purposes of Medicaid, we are actually getting a more restrictive standard, a more restrictive reimbursement standard for audiovisual. Because right now, audiovisual is permanent in law with regard to Medicaid. This would make it only available for 2 years. And then when we add in the payment parity standard right now in Medicaid, audiovisual is reimbursed the same as in person. This payment provision would change that. So I think we need to separate out the audio visual from the audio only in this provision.
So I'm actually going to break my own rules and respond to that. So I guess what I'm asking everyone to do is to think of this bill as laying the foundation to understand the full capacity, impact, and utilization of all kinds of telehealth. We aren't, we don't have enough in my perspective, we do not have enough information right now based on our experience prior to the pandemic and during the pandemic of how to use telehealth, all kinds of telehealth, to its best advantage post-pandemic. So these dates that are in here presume that we are going to have a report in December of 2022 that's going to guide us how telehealth should be treated, how it should be used, how it should be reimbursed, based on the study that MHCC is doing. So if we need to say, during the period of the study in this language so that it makes it clear that we anticipate that there will be changes, because I fully do anticipate that there will be changes based on the study, then we can do that. But I'm hesitant to take the dates out and understand if we need to separate those two things, then we can do that. Jen Witten.
Thank you, Delegate. I appreciate that and appreciate your thoughts. So a couple of just reaction to the conversation in this section as well. I think my comments were similar to Ellen Weber's and have some also thoughts around some of the prescriptive Medicare language. So the last meeting we had before us language that was provided that we really focused on trying to define what an audio-only consultation service would be and what it would not be. And as it was just pointed out, audiovisual healthcare services would be considered synchronous technology. And I would respectfully just say that even before the pandemic, we have several excellent examples of significant telehealth programs throughout the state that have been delivering services for decades, quite frankly. We would be rolling back significant policies by taking this approach to limit both audio only and synchronous technology that has had several years of experience. And so I'm concerned that by potentially rolling back some of these provisions, we would have a number of initiatives that have had significant investments that would be concerned in moving those forward. And we will have access issues. I was contacted just this weekend by a couple of constituents who testified before this committee who are already experiencing denials in some telehealth coverage. So respectfully, I think this would be very concerning for our members. And as it relates to some of the provisions in section, well, now it's under 3, putting these really, again, prescriptive points of time on a consultation would in essence make audio only not a viable solution for providers. The complexity of trying to make these determinations while making real-time clinic decisions would make this not valuable. So our study, therefore, would not have the data to really drive any kind of good results or give us the kind of information we need to make for further determination. So we do have concerns with this section generally. Thank you.
So I need to ask, in terms of what you spoke to first, what about this language would change your current programming for the next 2 years? What would force you to not do something that you are currently doing over the next 2 years while the study is being done?
Thank you, Delegate. Appreciate that. And I know we've got a number of hospital members here. So there's infrastructure involved here. There's technologies. We have one of our providers who I don't believe was able to join us today, Kennedy Krieger, where they invested in tablets and other technologies for their patients. If there is a potential not to reimburse for just even those synchronized technologies that they have had reimbursement for in years previous, I think that there would be a hesitation in terms of building out those potential programs after this 2-year mark. And again, I think the audio only would just not even be a viable solution for them.
Okay. I hear you. So let's go to Ann Seacott.
Thank you, Madam Chair. I guess I have a question, as Ellen actually asked, about the dates. Is it proposed that the dates in this section limiting the bill, the audio and audio visual to these 2 years, is that instead of sunsetting the bill? And if not, it's just a question as to why it needs to be in 2 places.
It's not instead of the sunset, but it's making it clear that we are operating in a status quo going forward over the next 2 years. So we're, as I said, I think, as I started off, we're gathering information that we really need to make sure that the telehealth program, which is essential, that it needs to be, robust and works well. But we're going to take a couple of years to really look at it. And that's what's intended in this language, that we're going to hold everyone harmless, even because we made some provisions during the pandemic that did not exist before the pandemic. And with the things that we made, provisions that were made are going to be maintained in place through these 2 years as we do the study. So that's sort of what we're trying to do is protect a decrease or a change in that language. Is that?
I appreciate that response. I guess, the concern is, are we though actually stepping back from anything that had been in place pre-pandemic? And I think that's where the question about putting audio visual in here raises.
Okay. Delegate Bagnell.
Thank you, Madam Chair, and thank you for all of your work on this. I think I just have the same concern about identifying the timeline, and I think your offer of language around a study is very good to address the concern that I have, which is disincentivizing behavioral health providers to invest in audio only, because it has been effectively utilized throughout the pandemic and at a greater rate than we expected. And has actually created for people, behavioral health community, a continuity of care that I think we want to be able to continue forward.
Great, thank you. Laura Mitchell.
Good afternoon. Thank you for holding this discussion. I reiterate agree with most of what I've heard in the last few minutes, but I also wanted to point out one other thing that you mentioned in here. The addition of the language about not covering a visit that results in an in-person visit within 24 hours could be very detrimental. I've had situations in both mental health and somatic health where I wasn't feeling well, had a terrific headache or something, and had a televisit with my provider. And the next day I was much worse. My blood pressure tanked or something changed, and I ended up having to go in. And both of those visits were covered. I've also had situations with my grandson and with other family members, myself included, where I had a visit one day for mental health services, a counselor visit, and the next day, something happened overnight or something happened the next day that was very troubling or catastrophic, and I needed to have another visit or an in-person visit. And I just worry that we may not be able to get that immediate care that's needed, and that may end up in a hospitalization or other more expensive treatment because they won't see us within 24 hours for a second visit because they won't get paid.
But that's if the first visit is audio only, is what you're saying?
either way, if either of those visits is audio only, it looks like in the reading of that, particularly if I have an audio visit with my counselor today, and then tomorrow, something happens and I really need to speak to them again. As I read this language, that visit wouldn't be covered.
But your visit with your counselor is probably longer than 5 to 10 minutes. Let me, we're taking down questions, so I appreciate it, and we'll keep moving. I've got 4 hands up. I'm going to take these 4 hands, and then we're going to stop for today, and I'll consult with my committee and council and see if we can get another meeting this week to just keep plowing through this. So, Mansi Raswan.
Thank you, Delegate. And I think I want to just add a little bit on to the conversation that we've been having on this definition section. Very much, obviously, I agree that there's concerns that this could be taking us backwards. I do also want to point to the question that Anne had raised on the years here, and then the interplay with the payment provisions in the bill. So this seems like in this section under the definitions, we're actually talking about coverage. And that is something I think when we'd come together, we all agreed that we have already in the law requirements around coverage and coverage parity. And what we were really talking about were some of the reimbursement levels to try to hit on creating access and being able to scale up these services for providers. So I'd say that, there might be some unintended consequences here, though I appreciate the intent is to try to protect. We could have significant unintended consequences related to whether we're actually peeling back coverage of these services that we've had on the books for many, many years.
Okay. Okay, thank you. Laura Hale.
Thank you, Madam Chair. Laura Hale with the American Heart Association. Just wanted to reiterate some of the points that the Hospital Association also shared. The Heart Association shares those concerns and really wants to make sure that that access continues for the long run. There are some studies on some of the finer points, but want to reiterate the more general point that telehealth has worked in the past. This allows for more extension, and we've seen it work elsewhere, and we want to make sure that continued coverage for the long run with access and ease for our providers as well. So thank you.
Thank you, Laura. And the last comment is from Robin Elliott today. And like I said, we'll be getting back to you on this one. Robin.
Delegate Collison and committee members, thank you. Just wanted to circle back to a comment some of my colleagues made around putting audio, video conversations and visits in only a 2-year cycle. So as many of you know, I work with nurses and making sure that nurse practitioners were included in Medicaid's telehealth program was something that we worked on for a long time. They are included. I'm happy to report that, as well as nurse midwives. And just want to make sure that we preserve the ability of advanced practice nurses to do those video visits. It's really important in terms of chronic disease maintenance and care coordination. And so that is a priority for us. Thank you.
Great. Okay. I really appreciate all of your feedback. Now you've got the document, you've got a little more time. If you would take a little time to continue to look at it, and if we need a meeting this week, we'll figure out and get information out to you about that, or potentially we could take this back up next Tuesday in our regularly scheduled subcommittee. So with that, I thank you all very much for your patience and your willingness to go through. This is a really, really important bill. This is a bill that is going to frame a really important tool that healthcare providers are going to be able to use in the future. So I would like us to think, keep in perspective what we're trying to accomplish here. And so with that, that concludes the work of the day. Thank you all. Have a great afternoon.
Thank you.
We going into full committee now?
Figured you were there.
1:30, right?
1:30? All right, well, I guess.
It's the same link that we're going to use for committee?
No, different link.
Okay, I'll go ahead and get off.
I was just wondering when we were coming back.
Yeah, I heard 1:30. I can run and go grab something to eat. Where you going, Ken?
I brought something here to the office. I'm thinking I might go back and do this at the hotel where I have the 2 screens set up. Because it's hard to like watch the Zoom and bring up documents and stuff with a little laptop.
It is. Yeah, I have my 2 screens set up in here in the office.
Yeah, I inquired about another screen, but haven't gotten it yet. So I think I'll just go walk down the hill and go re-adjourn there.
All right.
All right. See you in a half hour.